Okay, so good afternoon, colleagues. First of all, let me extend a warmest welcome to all of you for joining us in this trabeculectomy course this afternoon. In my talk, I'll be talking about some basic steps in trabeculectomy and also some tips and pearls. First of all, let me just stress that this is not meant to be a comprehensive account of trabeculectomy. I'm assuming that all of you have already read the basic textbooks on how a trabeculectomy is done and on some variations of trabeculectomy. So what I'm trying to do today is to supplement what you have already read. Okay, so what I'm going to do is I'm going to share with you how I do my trabeculectomy with some tips and pearls along the way. I'll explain to you why I prefer to use those particular techniques or particular steps. And of course, at the end, hopefully I'll have enough time left for some discussion with all of you if you have any questions at all. Now, for financial disclosures, I just want to say that in this talk, I'm going to talk about several instruments that I frequently use in my trabeculectomy, but I have no financial interest in those instruments. Now, to give you an overview of glaucoma treatment, I normally would like to place all these different kinds of glaucoma treatment along what I would call a treatment spectrum. So from top to bottom, you're starting from those treatments that have a less IOP lowering power, they have lower risk, and they're less surgically invasive. Whereas as you move down, they become increasingly stronger in IOP lowering, they have higher surgical risk, higher risk of complications, and they become more invasive. So starting at the top, of course, we have drugs, and then we have trabeculoplasties and cyclodestructive procedures. Cyclodestructive procedures nowadays are more or less completely by laser, and in terms of IOP lowering and invasiveness, it is perhaps quite comparable to trabeculectomies. And then going further down, of course, we have all the mixed and then non-penetrating trabeculectomy, and finally the conventional filtration surgery such as trabeculectomy and also a glaucoma drainage device implantation. So this set the scene for what we're going to talk about today, trabeculectomy. Now, before we talk about the procedure itself, I normally stop all glaucoma drugs in the operated eye at least 3 to 7 days before surgery. The idea is twofold. First of all, the drugs increase conjunctival inflammation. And secondly, I want to, in particular, stop all aqueous suppressants so that the aqueous is being produced at a more physiological rate. By doing that, I can ensure that immediately after my filtration surgery, I'll have enough aqueous to drain through the fistula so as to maintain the patency of the fistula as well as to maintain the subconjunctival space. So I normally stop the drugs several days before surgery, and how many days really depends on how high the intraocular pressure is and how advanced the glaucoma is. If the glaucoma is very advanced, the pressure is very high, then I may stop the drugs for a shorter duration, such as 2 to 3 days. Or alternatively, if the pressure is not too high and the glaucoma not too advanced, then I may stop the drugs for up to 7 days before surgery. Now, secondly, when I stop the glaucoma medications in the operated eye, I start topical steroid. So I routinely start topical steroid before the procedure so as to minimize the amount of inflammation around surgery. Now, what I'm going to do is, first of all, I'll show you a video. I'll show you quietly this video, which lasts for about 2 minutes long. So I'll let you just observe how I do the trabeculectomy. And then afterwards, I'll go through some individual steps in which I feel that many textbooks are not covering adequately, or maybe I have my own specific views or unique preferences. And then finally, at the very end, I'll show you this same video again to explain some of these steps. So first of all, let me share with you the video uninterrupted. Okay, now let me talk about some of the individual steps. Now, first of all, here's an overview of my procedure. In terms of anesthesia, I more or less routinely use topical anesthesia with silocaine gel. And this same principle applies also to my phaco trabeculectomy. I think the major reason why I prefer topical anesthesia is because I do not want the increased intraorbital pressure associated with peribulbar or retrobulbar injections. With that additional pressure in the intraorbital space, it will affect your judgment of the filtration rate when you try to fine-tune the tightness of the sutures, of the scleral flap sutures. So I try to maintain the orbital space in a normal physiological pressure without peribulbar or retrobulbar injections. Secondly, I also do not want additional pressure on a very fragile optic nerve. So more or less routinely, I use topical anesthesia with silocaine gel. And for those patients who are particularly anxious or sensitive to pain, I may consider adding additional intracameral preservative-free lignocaine 2%. But I probably only do that in about, I would say, 5 to at most 10% of my patients. And then for better exposure, I prefer the use of a fornix-based conjunctival flap. And when I apply the mitomycin, I try to apply it over a very large, diffuse, and posterior space around the scleral flap. And I'll come back to this particular point later on. And then finally, my scleral flap is routinely closed with 2 10-0 nylon sutures. And normally, I would tie the sutures tighter to allow only very mild seepage of aqueous on table, with the plan that after surgery, usually at about 1 to 2 weeks after surgery, I'll perform laser suture lysis to further increase the outflow once the conjunctival wound is stable. And I'll also come back to this point in greater detail later on. Now, the conjunctival closure, I prefer to use 10-0 nylon sutures, usually just 2 10-0 nylon sutures with both of them rotated. I think this gives the best comfort to the patients. And also, before I tie off the final conjunctival 10-0 nylon suture, I inject mitomycin C in the space around the scleral flap. Usually, I inject around 0.2 mils of 0.4 milligrams per mil of mitomycin. And additionally, I may give dexamethasone injection as well, usually up to 1 mil, 4 milligram. Another point I want to stress is I always try to remove the eye padding early after surgery, usually 4 to 6 hours after surgery. The idea is that I want to re-establish the flow of aqueous. I want to establish the flow of aqueous through the fistula and into the subconjunctival space early on after surgery. Because by doing that, you keep the fistula patent and you maintain the subconjunctival space. So I think this is very important, and this is also made possible by using topical anesthesia. Because if you use peribulbar or retrobulbar anesthesia, it may take you a bit longer before you can safely remove the eye pad. And also, the earlier removal of the eye padding allows the earlier starting of topical steroid. So usually at 4 to 6 hours after surgery, I remove the eye pad and then start topical steroid. Okay. Now, one other point I just want to stress is far too often, I think we are giving topical antibiotics for too long after the surgery. I often see patients still being on topical antibiotics 1 month, 2 months, or even 3 months after the surgery. In fact, the topical antibiotic is quite pro-inflammatory. It induces inflammation, it induces congestion, redness, etc. in the conjunctiva. And so I always try to stop my topical antibiotics early on after surgery, and usually at 1 or at most 2 weeks after the surgery. But the time when it is safe to stop the topical antibiotics is when you see that the conjunctival wound edge is well epithelialized and safe. So I stop the topical antibiotics early after surgery and continue only the topical steroid. Usually I continue the topical steroid for as long as it is necessary to remove or to alleviate most of the conjunctival inflammation. So when the conjunctiva is less inflamed, is less reddened, is less vascularized, then I will consider taping down the topical steroid. Now, this is an eyelid speculum that I frequently use for my trabeculectomy. The main feature of this speculum is that on one side, the wire loop is much longer. It's much longer and goes much further away. And for this particular speculum, there's a left-sided speculum and a right-sided speculum. So you have to use the right one for the correct eye. And the idea is that the wire loop that goes into the inferior fornix should be the one with the longer and deeper U shape. And with this design, the eyelid speculum manages to rotate the eye downwards, even without a bridle or corneal stay suture. Okay, so this is a very clever design, but having said that, I've noticed that it may not work in all patients. In some patients, the eye does not rotate downwards, even with this specific speculum. But at least, I think, even in those eyes, this speculum would be as good as any other speculum that we normally use for intraocular surgery. Okay, next, I want to talk about Tinnonectomy. And I only perform Tinnonectomy when the scleral surface cannot be visualized through the conjunctiva. Okay, so intraoperatively, after I've raised the conjunctival flap, I pull the conjunctival flap back, covering the scleral surface. And if the scleral surface, as well as the vessels, the episcleral vessels, cannot be visualized through the conjunctiva, then the conjunctiva is too thick. And I perform Tinnonectomy to allow me to visualize the scleral surface through the conjunctiva. This would make subsequent laser suture lysis much easier. Okay, and I only do the Tinnonectomy over the area where I will likely be performing laser suture lysis. I don't do extensive Tinnonectomy. Now, I apply mitomycin more or less as a routine, unless contraindicated. This is because in Chinese eyes and in Oriental eyes, the fibrosis, inflammation as well as fibrosis tends to be a more commonplace. And furthermore, in fact, in our setting, most patients, if not all patients, have been on multiple glaucoma drugs for very prolonged periods of time. And this leads to a lot of chronic inflammation in the conjunctiva. And so I think mitomycin is more or less needed in the vast majority of cases, unless contraindicated. Now, my standard regime for mitomycin is a 0.4 milligrams per mil for 3 minutes. Now, one important point is that I always cut those sponges from instrument wipes myself. I always do it myself, and I'll always cut 9 pieces, all of the same size, constant shape. I think consistency is the key here, because it is only by doing it in exactly the same fashion every time, you manage to fine-tune your techniques to get the best results, to get the best postoperative outcomes. And also, the fact that all your sponges are of the same number, same size, same shape in every trabeculectomy that you do, that will allow you to notice if one sponge or part of a sponge is being left behind in the eye. Okay? This may sound silly, but it happens again and again. Sponges being left in the eye, or part of the sponge that have broken off being left in the eye. And if you have a consistent number of sponges, as well as constant size and shape of the sponges, then the risk of this happening is much reduced. Also, my other tip is that sometimes I see surgeons immersing those sponges in a tub of a lot of mitomycin. They're basically inside a pool of mitomycin, and when you take up the sponge, it is dripping with mitomycin. I try not to do that. What I normally do is, with these 9 small pieces of sponges, I only apply 1 to 2 drops of mitomycin over the sponges. So in other words, I apply only enough mitomycin to just soak each sponge. When I take up the sponge, it is wet, but it should not be dripping mitomycin. Okay? By doing that, I will be applying mitomycin only to those places where the sponge is. And I won't be flooding the wound with mitomycin. The whole aim of this is that I try my best not to allow the conjunctival wound edge to be exposed to mitomycin, because that would affect long-term wound healing. Now, during the application of mitomycin C, I routinely use the core conjunctival clamp, which is produced by Duckworth and Kent, which is shown in the photo here. The beauty of this design is that at the end, it is T-shaped. And so the pressure or the force over the conjunctival wound edge is widely distributed. It's widely distributed over this a longer edge. So you will not be distorting the shape of the conjunctival wound edge, and there's a much reduced chance of tearing the conjunctival wound edge. And secondly, you can see this serrated edges, which allows you to hold the conjunctival wound edge very tightly. And also, when this instrument is when you're not pressing on this instrument, it is actually closed by a spring mechanism. Okay, so once you have secured it over the conjunctival wound edge, you do not need to apply any force, and you can just hold the conjunctiva up with this clamp very safely, without tearing, without distorting the wound edge, and you can also protect the wound edge from exposure to mitomycin. Now, when I applied the mitomycin C, I tried to apply it to a wide, diffuse area and the more posterior area surrounding the scleral flap. As I said, I tried my very best to avoid touching the conjunctival wound edge with mitomycin. And the ultimate aim of applying mitomycin is to achieve a more diffuse, a low-rising, a partially avascular bleb. You don't want the bleb to be completely avascular. And also, you try to avoid the completely avascular and thin-walled and cystic blebs. Okay? After mitomycin C application, I flush the wound with 20 mL of balanced saline solution. And only after this, then I decide if there are any vessels that need cautery. I very seldom do cautery before the application of mitomycin C, because the mitomycin C application sometimes allows a lot of the bleeding to stop by themselves. And I'll try to do as minimal amount of cautery as possible, because once again, this is damaging to the tissue and it induces inflammation. So after mitomycin C application, if there's still the bleeding from some of the vessels, the bleeding is large enough to worry me, then finally I'll apply some cautery. Now, I normally use the Kelly glaucoma punch to create the inner sclerostomy. And very shortly, when we go back to the video, you can see how this Kelly punch works. Basically, when you press on the lever up here, this part of the instrument will go in. Okay, it will go in and it will cut. It will basically bite the edge of the sclera to create inner sclerostomy, and it gives you a very consistent size of the bite each time. So you can also, this also helps you to maintain consistency in creating the size of the inner sclerostomy. Now this figure here shows you how this punch works. So it basically bites off part of the sclera to create the fistula, to create the inner sclerostomy. And I think the beauty of this instrument is that it is easy to use, and it also allows you to achieve a very consistently sized inner sclerostomy site. Okay, now after going through some of the tips and pearls, let me go through this video with you once again, and I'll stop along the way to talk a little bit more about each individual steps. Now, in the very first step, normally nowadays, this video actually dates back a number of years now, and there are certain steps that may not be exactly the same as how I'm doing it today. And I'll tell you what these steps are. First of all, nowadays with the use of the Eyelid Speculum, I think most of the time I do not need to use the silk suture, the corneal silk suture, to rotate the eye downwards. Most of the time I don't need this step. And also, because I'm using topical anesthesia, in those patients who are more cooperative, I can ask them to look downwards during the procedure. So nowadays, most of the time, the corneal silk suture is not necessary. But if this is really necessary, then what I would use is a 6/0 silk suture with a spatulated needle. Then I apply the suture, I apply the needle through the cornea, through the peripheral cornea, about half thickness through the cornea. And I also want to make sure that I'm applying it at a position where it will not interfere with my subsequent suturing of the conjunctival wound. Okay, so you have to have an idea in your mind where your conjunctival wound is going to be and where the two 10-0 nylon sutures are going to be, and you have to apply the corneal bridle suture at a location that will not interfere with the position of your 10-0 nylon sutures subsequently. Okay. So once you've applied the corneal suture, you can use it to rotate the eye downwards. And then, now in these steps, what I'm doing is, of course, you have to use a forceps without a sharp teeth at the end. So what I normally use is the Downs forceps, which has a more or less straight edge at the end. And the idea is that you don't want to punch holes or tear the edge of the conjunctival wound. So never use 0.12s for this purpose. Okay, I routinely use the Downs conjunctival forceps to hold the conjunctiva, and I use the curved corneal scissors to create a large pocket, a large subconjunctival pocket surrounding the scleral flap. You can see that I pass the scissors quite far back, and then I divert the scissors so as to create this subconjunctival space by more or less blunt dissection. Okay, so you can see that I lift up the conjunctival wound edge and then use the scissors to widen and create the subconjunctival space. So just now, I used the Took's knife to remove the episclera together with some of the episcleral vessels. And okay, and if necessary, then I'll apply some cautery. But nowadays, more or less, I leave the cautery till after the mitomycin C application. Now you can see the core conjunctival clamp working now, and with the edge of the conjunctival wound lifted up, then I'll apply 3 sponges. You can see that I push them back in. I'm not leaving the sponges immediately over where the scleral flap is. I push them in posteriorly as well as into a more diffuse space surrounding the scleral flap. I normally put in 3 sponges for 1 minute, and then I replace these 3 sponges with another 3 that are fresh, and I timed another 1 minute. And then I replace the second lot of 3 with the third lot of 3 fresh sponges with mitomycin C for a final 3rd minute. Okay, and then after that, after 3 minutes of conjunctival, after 3 minutes of mitomycin C application, then I flush the whole surgical site with 20 ml of balanced salt solution. Okay, and then at this juncture, before you enter the anterior chamber through the scleral flap, of course, you must create your paracentesis, usually with a 15-degree knife. This is to make sure that just in case you need a anterior chamber reformation afterwards, or you need anterior chamber access at some stage, you already have the paracentesis site safely created. And then I use the caliper to measure what I normally measure 4 millimeters for the more or less horizontal cut, and then 3 millimeters for the vertical side cuts. So this here, I'm measuring 4 millimeters. And then I use a crescent knife to make the initial cut. The initial cut should be roughly about 3/4 depth of the scleral flap. And then I use the crescent knife to create a scleral tunnel. The scleral tunnel is then at about half scleral thickness. So in other words, the initial cut is deeper than where the horizontal cut is going to be. the initial cut is roughly about 3/4 scleral thickness. And then I use the same crescent knife to create a scleral tunnel at about half scleral thickness. On the one hand, you do not want the scleral flap to be too thick, because otherwise you run the risk of premature entry into the anterior chamber. And on the other hand, you do not want the scleral flap to be too thin, because otherwise it will be difficult to control the rate of outflow of aqueous. So half scleral thickness is very important. And the way to judge that is that when you're using the crescent knife to go gradually, stage by stage, when you create the scleral flap, you should always be just able to see the shape of the crescent knife over the scleral flap. Okay, so if you are going too deep, you may not see the shape of the scleral of the crescent knife at all through the scleral flap. And then now at this stage, we'll create the two lateral extensions of the scleral flap. In the past, I more or less very often inject viscoelastic, as shown in this particular video. In the past, I very regularly inject viscoelastic before I create the fistula, but nowadays I don't do this routinely. So I just maintain the anterior chamber with aqueous or balanced saline solution, and then I create the fistula. But of course, if you are worried about hypotony, or if you are worried about a sudden change in pressure of the eye, then injecting viscoelastic is also a good idea. So in this step being shown now, I'm using the Kelly punch to create the inner sclerostomy. You can see that I catch the edge of the sclera, take a bite, and then I use a Downs forceps. I use a Downs forceps to pull out a little bit of the peripheral iris and use a veneer scissors to make a cut. This step is potentially painful. Okay, so I normally warn the patient that he or she may feel something immediately before I make the cut. And also, in those patients who are very anxious or who are very sensitive to pain, it could be an idea to give some intracameral preservative-free lignocaine before this particular step. And then finally, I use a 10-0 nylon sutures, usually 2 of them, to close off the scleral flap. Usually, my first suture will be slightly tighter. The one on the left is usually a little bit tighter. It is rotated so as to minimize discomfort. And then for the second suture, I normally make it loose, slightly loose. Okay, so with the aim that there should be aqueous percolation through the fistula during the surgery, and on table. If there's absolutely no fluid coming out, then the fistula is not working. You want to aim for very slow percolation of aqueous while on table, with the anterior chamber very stable and well maintained. And then finally, it's the closure of the conjunctival wound. In this particular video, it was still in the days when I was using 8-0 or 9-0 Vicryl to close off the conjunctival wound, but nowadays I more or less routinely use a 10-0 nylon sutures, which I think gives the patient a lot more comfort. With the 10-0 nylon sutures, you should always rotate them so that you don't have a knot to irritate the patient's eye. Now, and then the dexamethasone injection subconjunctivally. Oh, in fact, one step what was not shown in this particular video is that nowadays I more or less routinely inject mitomycin C subconjunctivally. Usually, I do that before I close off before I apply the second conjunctival suture. I use a cannula to pass on far behind and peripherally, and then I inject about 0.1 to 0.2 mils or 0.4 milligram per mils of mitomycin C to have some additional antifibrotic effect. Now, finally, it's very important that you test the wound edge for leakage. You should not have any leakage on table, because if it is already leaking now, post-operatively, you'll be in a lot of trouble. So you must check very carefully for leakage. Some surgeons prefer to apply some fluorescein stain at this stage to look for leakage. Personally, I don't feel that is necessary, so I normally use a sponge just to wipe over the conjunctival wound edge to make sure that there's no leakage. Of course, you should also pressure test your conjunctival wound, and the way I do that is that I inject some balanced salt solution, balanced saline solution into the anterior chamber with some pressure, so that there's more aqueous coming out through the fistula to lift up a bleb. And when there is a bleb and there's still no leakage through the conjunctival wound, then your conjunctival wound is very safe. Okay, so that concludes the surgery. Now, finally, I'll just go through a couple of scenarios that I feel are interesting and that I feel may be of use to you. First of all, post-operatively, if there is under drainage, I think the very first step you need to do is to perform a gonioscopy. Okay, you must perform a gonioscopy to rule out internal blockage of the ostium, of the internal fistular ostium by iris tissue, or perhaps by blood or by other things. Okay, so you must have a good look at the internal ostium to make sure that it is not blocked. And once you have confirmed that, then you can move on to the next few steps that I'm going to talk about. Now, if you feel that there is too high a resistance to aqueous outflow, of course, you may perform laser suture lysis, but do not perform laser suture lysis too early on, because if you establish quite a high aqueous flow early on, you may disrupt the conjunctival wound edge. So normally, I do not perform laser suture lysis within the first week after surgery. Okay, by the end of the first week, the conjunctival wound edge is more or less well epithelialized, and then it's much safer to perform laser suture lysis then. So within the first postoperative week, if the aqueous is draining too slowly, then I perform bleb massage for the patient. At this stage, it's probably no use asking the patient to perform self-massage himself or herself, because the patient will be too anxious to press on an eye that has just been operated. But what I normally do is I ask the patient to come back, sit at the slit lamp, and then use a Q-tip ask the patient to look down, use a Q-tip over the upper eyelid to apply pressure so as to raise a bleb. And if necessary, I do that every day for the patient. Okay, I want to make sure that every day I'm stretching the fistula, not allowing it to adhere together, not allowing it to close. And every day I maintain or re-establish a bleb so that the conjunctiva is not sticking down to the scleral surface. Sometimes if you feel that the eye is very inflamed, you may even do that twice a day. Okay, the important idea is that early on after surgery, when the eye is still inflamed, all the tissues are still very sticky, you would not want the fistula or the subconjunctival space to close off. So applying bleb massage is extremely important. And then after 1 week or so, when the wound edge is well epithelialized, then you may consider argon laser suture lysis. In fact, of course, there are other things you can do to increase, other techniques you can use to increase post-operative outflow rates, such as releasable sutures, but I'll leave that to a more advanced course in future. I think for most people, argon laser suture lysis should be the easiest approach. Okay, now let me show you how I perform the Oculum Massage. You can see that this eye there's not much of a bleb immediately after surgery, and so I ask the patient to look down at the slit lamp, and I use a Q-tip over the upper eyelid to apply pressure. Do not apply pressure directly over the scleral flap, because if you do that, the aqueous cannot come out. Okay, so you apply posterior to the scleral flap, and you can see that the aqueous is coming out and raising a very nice diffuse large bleb in this eye. Okay, now ocular massage is only useful if you can raise a bleb. Okay, if you apply a lot of pressure and the bleb cannot be raised, then the fistula has already closed off. And under those circumstances, there's no point in repeating the massage either yourself or asking the patient to perform ocular massage at home. If it doesn't raise a bleb, it doesn't work, and there's no point in further performing that. In fact, in later stages after surgery, sometimes I do educate my patients and ask them to do ocular massage themselves at home, usually 3 times a day for 10 minutes each time. And after I've taught the patients how to do it, I normally ask them to do it in clinic. And I observe the bleb before and after their own massage at the slit lamp to make sure that they're doing it correctly. Okay? Far too often, we just assume that our patients know how to do the ocular massage, ask them to go home and do it. And most of the time, they're not doing it correctly, and it is serving no useful purpose. Now, let me just talk very briefly about argon laser suture lysis. In fact, of course, the indication is if there is inadequate drainage. And the best time window, if you are not using antimetabolites, it is you probably have to do it around 1 week after surgery. Whereas if you are using antimetabolites, it is still useful up to 2 or 3 or sometimes even 4 weeks after surgery. It is still useful. Okay, and nowadays more or less we routinely apply antimetabolites. So I've left this. If no antimetabolites, I left this in italic. Now, there are several different types of suture lysis lenses that you can use, but personally, I prefer to use the rich laser suture lysis lens, which is shown here. And of course, there are other types as well. And my laser settings for suture lysis I usually start at 400 milliwatts. If necessary, I increase that further. And the spot size, I start with 50 microns with a duration of 0.05 to 0.1 seconds. Now, this is what you would see through the lens. You have to apply some pressure over the suture, because when you apply pressure, you displace any fluid or displace any swelling over the suture. And once you have applied pressure, you should be able to see the suture very clearly. Okay? And when you cut, I always suggest that you should cut somewhere in the middle. Now, it is not a good practice to cut very close to one end of the suture, because say if you cut somewhere over here, then the very short suture stub will stick up. Okay, it will stick up, point upwards, and that will irritate your conjunctiva, and sometimes it will even puncture your conjunctiva. All right, so always try to cut somewhere in the middle so that the two suture stubs are still long enough that they lie flat over the surface of the sclera without irritating the conjunctiva unnecessarily. Now, suture lysis, even though it is relatively safe, it is not completely complications-free. It may result in overdrainage, conjunctival wound disruption, especially if you perform it too early on. And of course, sometimes it can cause conjunctival tear, especially in those very inflamed conjunctiva. And sometimes it can cause a subconjunctival hemorrhage, which is not good news. Whenever you have blood in and around the area of your bleb, it is not good news because it induces wound healing. Now, just one final comment on under drainage. If you see under drainage very, very early on after surgery and the pressure begins to go up a little bit higher, do not resume glaucoma drugs too easily. Okay? Because once you have resumed glaucoma drugs, the topical drugs, you have already surrendered. Because by reducing aqueous production or by increasing uveal scleral outflow, you are diminishing the amount of aqueous that will be flowing through the fistula. And by resuming glaucoma drugs, this will lead to bleb failure, to filtration failure. It will increase the chance of filtration failure. So always try your best to rescue the bleb, either by massaging, by laser suture lysis, by releasing releasable sutures, etc., 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 and try your best not to resume glaucoma drugs until you feel that the filtration, the fistula is no longer salvageable. Okay, so as soon as you start glaucoma drugs, more or less you're declaring defeat, you're surrendering. Now, in those eyes with over drainage, some textbooks describe the use of injection of autologous blood to induce some inflammation and induce some wound healing. But what I do in those situations is I actually perform more or less like a needling procedure. But instead of using the needle to enter the anterior chamber and to widen the fistula, I use the needle to cut some blood vessels in and around the bleb, so as to release autologous blood into the bleb itself. Okay, I find this quite a neat technique. I do not have to take blood from the patient's veins and then inject the blood, etc. I find this much neater than the conventional technique, and I basically release the autologous blood from blood vessels in and around the bleb. And of course, the autologous blood can be combined with compression sutures, and that will make the overall procedure even more effective in dealing with the over drainage. So that more or less sums up all my tips and pearls this evening. And before I go off, allow me to just put up a very small advertisement. Many of our colleagues and I myself, and also a number of very distinguished clinician scientists in glaucoma field from the Asia Pacific region have co-authored this textbook on primary angle closure glaucoma, which is now available through the Springer online shop as well as through Amazon. So if you are interested to read more about primary angle closure glaucoma, you can go towards this textbook. So thanks very much once again for your time this evening. If you have any questions at all, please feel free to either ask now, or alternatively afterwards, you can always come to me, drop me an email, send me a WhatsApp, and we can discuss the tips and pearls for trabeculectomy further.